tract cancer trials done in UK by Dr. Marie McNamara, where you can see in the right side of the screen on solid green what is the median survival of most of the time advanced gallbladder cancers is only 8 months compared to other type of biliary tract cancer. When we talk about the epidemiology, what do we need to understand about gallbladder cancer? Well, first of all, we need to understand there is a sex difference in gallbladder cancer. In the United States, for example, it's about the ratio between women and men, 2 out of 1. In Chile, where there is a high incidence of gallbladder cancer, in certain region of subpopulation of Chile, that can be even higher than 5 times higher from women than men. As we know, the epidemiology of sex difference in Eastern countries like China, for example, is more men than women. Mortality in gallbladder cancer, although has been decreased largely proportion in all the countries, there is still a trend of subpopulation in every country. And I put the example of United States, when we still have Black American patients who are increasing in 1.8% per year the incidence of gallbladder cancer. And that has similarly happened in Ecuador, where we have a decrease of incidence, but still a high trend of mortality, and also in Germany. So that's make you understand that there is a geographic disparity in gallbladder cancer. It's rare in most countries that we know, but there is remarkable difference where we can actually find 40% of gallbladder cancer incident concentrated only in South America, South Asia, and Southeast Asia. And this is the classic picture that we see of a heat map of incidence of gallbladder cancer disparate in the entire world, where we see, for example, location as in South America, where in 2010, with the global can, incidence of gallbladder cancer was leading by Chile with 9.7, and the lowest was Argentina with 3.3. But this has been updated. Now the high incidence is Bolivia with 8.5. And Chile is actually having 5.6, and Argentina is pretty much matched with Ecuador with 1.1. Where Bolivia, this is a region of Bolivia that is pretty significant for gallbladder cancer still, and is understudied most of the time. With you can find up to 9% of the laparoscopic cholecystectomy specimen with gallbladder cancer. And this is also in the region of the south of Peru. This disparity on geographic is also found in India, for example. When we talk about India being a high incident in gallbladder cancer, we need to talk about the north of India, not the south, specifically a region close to Bangladesh. Same happening in Japan. We have done multiple collaboration with Japan, and some of the institutions, major institutions, they say, well, we don't have that many gallbladder cancer. Well, the problem is, Dr. Vega, you've been asking for the wrong institution. The gallbladder cancer is also located in the north and south of Japan. Same happened in Korea. It's not all South Korea where it's a high incident gallbladder cancer. You can see that in the region of Ulsan, it's 7.5. In the other region, for example, it's 4.7. Europe happened similar. Eastern European country are the most incident of high incident of gallbladder cancer, never as much incident as I present already in South America or in Asia. But there is a trend, not only for gallbladder cancer, for biliary tract cancer around Europe is increasing, so we need to know better. We can give you an example from München. We have the register, and in Germany, we know that the trend of gallbladder cancer is increasing. And this is compared with the SEER database in America. Let's go to Estados Unidos, United States. We can see here, and this is a pretty nice graphic where you can actually see difference between incidence rate and mortality rate. Incidence rate up in the map, heat map in the top. You see incidence rate high in Texas or New Mexico, but actually mortality rate higher in what we call Midwest region that are actually don't have that much incident. What is a call for maybe under treatment of gallbladder cancer. What do we know about the trend of research? It's been called gallbladder cancer the orphan cancer. It's because no one was doing that much studies, being the first biliary tract cancer around the world. It's been going better and better. We have the trend, it's a logarithmic trend. And what country, I'm sorry, it may be small, but what country are leading this? China, United States, Japan, India, South Korea. I'm very proud to say that Chile too. And let's talk about current consideration that may put the table of what we're going to have to talk later on. 21% of the population was covered by cancer register in 26. Mortality, 1 out of 3 proportion of covering of register for mortality. So we don't know much about what happened in almost a half of the register. This is the availability of the heat map of register for gallbladder cancer around the world. Gallbladder cancer has another controversy. It's a difficult diagnosis. Who can tell me where is the cancer here, if it is any? What's going to pathology do with this specimen? How is it going to choose where to find the gallbladder cancer? That's the reason why I've been advocated about gallbladder cancer mapping, even more when we have early stage of gallbladder cancer. Why? Because recent study in recent published indeed by Dr. Roa and a collaborative study saying that we actually miss staging T2 gallbladder cancer, and we say that it's T1. And this is an example that probably is too much for your eyes. You're not going to be able to see, but they mistaken in the lower amplification that there is a muscularis there, while we do in the box you see in the right, we don't see actually any muscularis. We just see ink that is a little bit more pink than usual. Other thing that we have about incidental gallbladder cancer, how do we treat residual cancer, but not residual cancer when we have lymph node positive? What about when we do re-resection and we have cancer found in the liver? How do we call those patients? The staging doesn't actually allocate those patients to any upstaging status. How do we justify chemotherapy then for those patients? This is residual cancer. This is how bad it can be, even in patients who had good prognosis. To have N0, R0 patient, that's how bad is fine cancer in the residual bed of the liver. What do we know about chemotherapy? And we'll talk about that. So we'll be very brief. We know that we need it because the risk of recurrence is super high. 82% of the population will recur in the first 18 months. And as Professor Nagino used to say, this is too much for me to study. Prodige, one of the studies from French, didn't find any different. And if we go deep on that study, only 20% of the patient had gallbladder cancer. BILCAP, that we want to fight about BILCAP many times. You have to understand that whatever you think about BILCAP, only 80% or even lower was gallbladder cancer, including that trial. So we have hope. It's coming. The study by Professor Sigur Marte from Emory University. He's the PI of the study and the clinical trial, trying to decide whether perioperative chemotherapy does help. This is important. And it's more important because it's a pure gallbladder cancer study. German is also doing that. It's the GAIN trail study. However, we will find probably some power of those trials because it does not have only gallbladder cancer, but also other type of biliary tract cancer. New therapies, we will say, well, we were very excited with our session of intrahepatic cholangio. Do we have new therapies? We don't actually. We have ER2 amplification. That's going to be the most. We don't have new therapy. We'll see what they pair in the future, but we need to be aware. So important point from this brief presentation of current controversy and epidemiology of gallbladder cancer. We need to know more frequent in women, except Asia. There is a trend to decrease, but there is a problem of certification of diagnosis, and it's a lack. We need chemotherapy. There's a lack of chemotherapy. Thanks so much.
Thank you, Dr. Vega. Dr. Lenoir said you covered all the topics. And I said, it's okay. We need repetition. It's after lunch. By the end of the hour and a half, we'll have seen some things more than once. So we'll learn. So I'd like to take this opportunity now to introduce Dr. Ganji from Cedars-Sinai. She joined their team in 2017 after completing her fellowship at Moffitt. And she's double board certified in general surgery and complex general surgical oncology. She serves as the director of the GI tumor program and cancer regional therapies at Cedars-Sinai. She specializes in the surgical management of hepatopancreatobiliary malignancies, metastatic colorectal cancer, and sarcoma. And her research focuses on understanding the role of the tumor microenvironment for metastatic neuroendocrine tumors and a molecule called SAME to attenuate chemotherapy-induced liver toxicity. Today, we've asked her to talk about what we often see, especially working at large academic centers. How do you manage the incidentally identified gallbladder cancer? And so, Dr. Ganji.
Thank you, Dr. Melstrom, for that very kind introduction. Thanks to the HPBA for the opportunity to speak today and the session moderators. She mentioned I'll be talking about the management of incidentally identified gallbladder cancer. I have no disclosures other than based on Dr. Melstrom's introduction, you know that I'm not a gallbladder cancer expert. So gallbladder cancer, as Dr. Vega mentioned, is fairly prevalent in different parts of the world. In the US, we see approximately 8,500 new diagnoses. We see more certainly internationally, like in Chile, India, and Japan. Generally, gallbladder cancer is thought to develop over the course of 5 to 15 years and progresses in the typical pattern that cancer will do, going from metaplasia ultimately to an invasive cancer. Unfortunately, progression is frequently silent, portending a poor prognosis, and we know that our best outcomes are in patients that we can diagnose early. However, most patients are not symptomatic. For purposes of this talk, we're going to define incidental gallbladder cancer as cancer that was diagnosed after pathologic evaluation of a cholecystectomy. This paper by Serrati et al. Looked at gallbladder cancers across the world and found that approximately 1 out of every 100 to 150 resected gallbladders ultimately had a diagnosis of an adenocarcinoma. In the US, incidental gallbladder cancer accounts for about 50 to 70% of diagnoses. If you look at the graphic, you can see that a majority of the time for these incidental gallbladder cancers, patients are diagnosed with T2 disease. Less frequently do we have T3 and T4 tumors. T4 tumors will typically have something on imaging that will basically suggest that there might be cancer present. So what is the role of re-resection? The audience certainly here knows that it's T-stage dependent. For early stage tumors, tumors in situ or T1A disease, a cholecystectomy is sufficient and there's no additional re-resection required. However, in patients who have tumors greater than T1B, there's a higher risk of residual disease, and as such, re-resection is recommended. Most importantly, residual disease, as we'll talk about a little bit later, is what defines overall survival. So what is the extent of re-resection that should be completed? There are numerous retrospective studies. We don't have any prospective studies in the management of incidental gallbladder cancer. So a lot of our data is essentially based on historic controls. I think the main goal is to obtain an R0 resection. And this was the expert consensus statement put out by the HPB that suggests that a re-resection should involve a partial hepatectomy. This could be performed via wedge resection, arguably 2 centimeters, and even that's debatable, potentially less. Or you could do a formal hepatic resection of segments 4B and 5. This should also happen in conjunction with resection of the hepatoduodenal lymph nodes. What we found based on retrospective data also is that formal resection of segments 4B and 5 do not necessarily portend better overall survival or disease-free survival. And as such, it's not necessarily routinely recommended. It's been found to increase morbidity in patients, which is why less aggressive resections are typically favored. What about lymphadenectomy? The biggest question is obviously which lymph nodes you should take. Here's a demonstration of the lymph nodes that drain the gallbladder. This was a study done where they injected indocarmine, and you can see essentially the cystic nodes, ultimately down to the retropancreatic nodes and down to the interaortocaval nodes are what drains the gallbladder predominantly. When disease is found in the cystic or perihepatoduodenal ligament nodes, those are considered N1 and N2 disease. And if it goes into the aorocaval nodes, that's considered M1 disease. So with respect to a lymphadenectomy, portal lymphadenectomy should be performed and is important for staging and prognosis. There is no overall survival benefit in these patients. Again, this is just information that allows us to then subsequently treat the patients. The incidence of lymph node involvement increases by T stage, which is not surprising. And lymphadenectomy has been found to improve survival in early stage tumors, but that's not necessarily true in T3 and greater tumors. 6 lymph nodes are recommended for resection, but for the audience, for anyone who's done a portal lymphadenectomy, you can clean out that entire hepatoduodenal ligament, and sometimes you don't get 6 lymph nodes. So that's why there's a star there, and other times you'll certainly get more. So certainly aim for 6. A formal lymph node dissection should be limited to the hepatoduodenal ligament. There's no evidence to suggest that extended lymphadenectomy benefits these patients. So why do we do re-resection? Well, you can see that there's better prognosis with patients who have re-resection. This was a study done by the AFC Gallbladder Cancer Group, published in 2011. You can very clearly see on the survival plot, re-resection portends better prognosis. It is, however, T-stage dependent, with patients with T1 tumors having 5-year overall survival rates of 100%, and that decreases to 0% for T4 tumors and only about 19% for T3 tumors. Again, this is not particularly surprising. We know that the incidental finding of residual disease for gallbladder cancer is also dependent on T stage, with patients with T2 and T3 tumors having higher rates of residual disease at any site, and certainly more frequently in the nodes compared to the residual liver bed. Does tumor location matter? This is potentially kind of the newest hot topic of discussion. This was a paper study published by Vote and his group in 2015, and essentially included over 400 patients with incidental gallbladder cancer, and tumors were defined as either hepatic-sided versus peritoneal-sided. There was a difference in how T1 and T2 tumors versus T3 and T4 tumors were defined. For T1 and T2 tumors, anything that was on the hepatic side was considered hepatic side, and the peritoneal side was a peritoneal side. For the T3 and T4 tumors, those tumors that were predominantly on the peritoneal side but had extension onto the hepatic side, not beyond the muscularis, were considered peritoneal. And when looking at overall survival, you can see for T1 and T3 stage tumors, there's no significant difference between the two groups. But in T2 tumors, patients who had hepatic-sided tumors had a significantly worse 5-year overall survival of 42% compared to 64% for the peritoneal-sided tumors. Additionally, and potentially not surprisingly, the residual disease in the liver bed was significantly less, almost negligible, in the peritoneal-sided tumors for the T2 cohort. And both groups did have lymph node metastases, but again, this was seen less frequently on the peritoneal-sided tumors. And the T2 tumors had higher rates of lymphovascular invasion, which again is not necessarily surprising based on these findings. So the current controversy is what's the role in these T2 patients, especially with peritoneal tumors, in re-resection of the liver bed. We still recommend lymphadenectomy given that the rates of lymph node metastases are upwards of 17%, even on the peritoneal-sided tumors. But some would argue that you can forego the hepatic resection potentially. What about port site excision? So the seminal paper was from Fong and his group, but this is another paper by Ethan from the Extrahepatic Biliary Malignancy Consortium. And it essentially looked at the role of port site resection, and there was no significant difference in patients who had port site resections versus not, both in patients who had basically all patients that were included, and then in patients who had residual disease present, either in the lymph nodes or the hepatic bed. So we've abandoned port site excision. And again, there's plenty of retrospective data to suggest that. What about bile spillage? Unfortunately, frequently we have no control whether this happens intraoperatively or not. Sometimes you're seeing these patients, and the best we could do is inform these patients that there are higher rates of peritoneal dissemination if there was intraoperative bile spillage, lower likelihood of undergoing a radical re-resection, and a lower likelihood of obtaining an R0 resection in these patients. Again, this is not surprising, but if you're aware that patients had bile spillage, it would certainly be important to complete restaging in these patients and potentially consider even a diagnostic laparoscopy prior to moving forward with re-resection. Additionally, bile spillage at index cholecystectomy is an independent predictor of shorter disease-free survival and worse overall survival. We know that residual disease is likely the biggest driver of how these patients ultimately do. This was a study published in 2014 by Jarnigan and the group, looking at the presence of residual disease. And for all stages, you can see those patients who had residual disease, whether it was T1, T2, or T3 tumors, compared to those patients who didn't, had significantly worse survivals. And the median disease-free survival was 11 months in patients with residual disease versus 93 months in those patients who were found to have no residual disease. So, and these patients also have significant early disease recurrences, with about 40% of patients having a recurrence locoregionally or distant at a period of 1 year. So the question really is, yes, we get a lot of these incidental gallbladder cancers, but is our approach of definitive surgical therapy first, is that the appropriate approach? And that's a question that's currently attempted to being answered with the study that Dr. Vega mentioned, also the ECOG 2197 or opt-in study. This slide is courtesy of Dr. Maythel, who's main PI for the study. But essentially, all patients who have T2 or T3 incidentally identified gallbladder cancers who have no evidence of metastatic disease on repeat staging essentially are eligible for this study. And there's a randomization to GemCis perioperatively as compared to upfront surgery alone. Both cohorts include a staging laparoscopy prior to definitive surgical resection. In patients who receive preoperative GemCis, they then complete their GemCis on the tail end post-surgically. In those patients who don't, they receive all of their GemCis post-surgically. The primary objectives are to evaluate overall survival in these patients, and then ultimately secondary objectives are looking at disease-free recurrence. So what are the final thoughts with respect to incidental gallbladder cancer? In the US, it accounts for up to 50 to 70% of diagnoses. The goal is to re-resect these patients to an R0 margin, whether you want to do it with a formal segment 4B5 resection or a wedge resection. We do recommend portal lymphadenectomy in these patients of the hepatoduodenal ligament. Prognosis following surgery is improved, but it varies, again, based on T stage. And most importantly, the role of neoadjuvant therapy in these patients is currently being studied. So certainly if you're in the US and you haven't opened the opt-in study, please consider opening that study and enrolling patients at your sites. Thank you very much.
So our next speaker is Javier Lendoa. He doesn't actually need much presentation. He was one of our past president and more prolific president, inaugurating multiple chapters in South America and helped to grow the society. He had a PhD and an MD from University of Buenos Aires, and now is the program director of Hospital Argerich de Buenos Aires.
Okay, Mrs. and Mr. Chairman, Lila, Eduardo, it's great to be here. And I will vote for the next meeting to have a bigger screen close, but it's very complex to the speakers to see the screen. So hopefully I brought my notes, but we are dealing with a complex issue here. So I have no disclosures, and I can say that I have to speak about non-incidental gallbladder cancer, that is also denominated primary, per-primum, or suspected, 4 denominations for the same type of a scenario, that represents 40 to 50% of the percentage of gallbladder cancer, but this according to the region, as Dr. Vega showed in his presentation. We know that this scenario in general is more advanced tumors and usually presents worse outcome. So in our updated series from Hospital Argerich, you see that this in almost 100 patients, 36% represent the number of suspected gallbladder cancer in our series, and the 5-year survival, overall survival in these resected patients is still poor and less than 20%. This type of scenario of gallbladder cancer can range from a local or diffuse gallbladder wall thickening to a polypodial tumor on the gallbladder, a fossa mass that is infiltrated by a tumor or an absence of gallbladder with a complex number of nodes and entrapped stones. So these are all patients referred to our unit. So non-incidental gallbladder cancer had been associated with worse survival in several studies. And we see this first study that showed less vascular invasion and more vascular invasion, more perineural invasion, and less differentiated tumors. But however, when we stratify patients and we analyze patients from this study about 10 institutions from US, we see that the comparison of non-incidental gallbladder cancer versus incidental presents a clear difference in the stage 3, but not in T2 tumors. So in stage 3, the non-incidental gallbladder cancer clearly is different and demonstrated difference in terms of survival. But why not in T tumors? But because this study from MD Anderson, 2 hospitals from Del Rio, Sotero del Rio from Chile, and Catholic University showed clearly that there is a difference between incidental and non-incidental tumors, showing that the incidental tumors show worse survival comparing with the non-incidental tumors in the range of 31%. And when you compare the interval between the first and the second operation, the survival was worse, as you see in this series from MD Anderson, that was 16%. And this probably is clearly related to a disruption in the natural barrier. And this is clearly a new path that you investigate that change the previous statements of this disease. So what about operative management? This is my topic about operative management. When you look back, what we have done in operative management is this disease, we clearly know that we did what we could, but the outcome is bad. And this is the reality we have now. And in terms of the steps of the procedure, we know that we recommend to continue recommending the routine use of staging laparoscopy, but we know the yield of this procedure range from 20%. This was demonstrated by a well-known study from India, from a Dutch study, multicenter study that showed 23% of yield in this disease. But we know that they still found patients that are unresectable at laparotomy in the range of 29 to 45%. So, which is the extent of surgery in suspected gallbladder cancer? Well, it involves a liver resection, that is a 4B5 or wedge resection in almost 50% of the patient. It involves a lymphadenectomy that can be an N1 or a regional lymphadenectomy. I will discuss this topic. And we use bile duct resection, but only selective. And this is the clear universal procedure, what is done. Lymphadenectomy is a problem. Different study, and which I'm showing 2 here, showed that only 20% of the patients received a lymphadenectomy that takes account of the numbers of required nodes of 6, according to American Joint Committee on Cancer Classification. So we know now that the vast majority of patients are still understaged. So we should think ourselves, is it time to do and to increase the number of nodes that are resected? Should we perform regional lymphadenectomy systematically? And why we think that? Because this extended lymphadenectomy not only came from the West, first from the Eastern series, but now is suggested and recommended by also from some Western hospitals and Western centers. So, and this is coming, and we analyze a certain station of the node, the posterior superior pancreatic lymph node, that is the stage 13A. We know that in T2 patients, 11 and 29% will have this node positive. But the survival, including this node in the lymphadenectomy, together with it will be the same as patients that are resected on lymphadenectomy with only N1 positive nodes. So why not including this stage of node, the posterior superior pancreatic lymph node, always in the lymphadenectomy? Something to think about. What about major hepatectomy? Well, people from Nagoya, that is the best group that has studied this, demonstrated good survival in persons with major hepatectomy, in 60 patients with major hepatectomy. But when we see and we analyze the results, we see that they use 87% of the patients were used portal vein embolization. The duration of the operation was almost 600 minutes. The complications grade 3 were 58%, and the liver failure was around 43% with a mortality rate of 5%. So this procedure must be done only in very selected centers and also in very selected patients, and it's using less and less. The same was demonstrated by a Dutch multi-center study. In this Dutch multi-center study, they demonstrated that comparing jaundice patients against non-jaundice patients, they demonstrated that the presence of lymph node metastases, together with the identifying in preoperative imaging the presence of nodes, also with location of the tumor outside the gallbladder neck, three aspects that you need to select to have good survival in jaundice patients. But at the end, the curve will show only very few patients that presents long-term survival. So it seems that this author recommend that you need to investigate the root cause of jaundice, and investigating this, you can select patients for extended procedures. What about hepatopancreatodenectomy? Orlando Torres demonstrated and showed a review about all series about HPD in patients with gallbladder cancer and with cholangiocarcinoma. And we know that from the different types of Kondo, Satoru Kondo that proposed the different types of advanced gallbladder cancer, there are certain that you can use for, especially for the resection in gallbladder cancer, applying the HPD procedure. But when we analyze the results, this European multicenter study clearly demonstrated that comparing cholangiocarcinoma against gallbladder cancer, the oncological benefit of the procedure, this procedure, extended procedure for gallbladder cancer, is clearly less beneficial than in cholangiocarcinoma patients. And almost 50% of these patients, usually the procedure for extended HPD is done during the surgical procedure, during surgery. So it's something that we need to have it only in very selected patients, and knowing that the survival is going to be very low. One study demonstrated recently that the surgery and extended surgery in gallbladder cancer is going down. And comparison of 2 decades with 313 patients suspected gallbladder cancer from the Memorial Group showed that the bile duct resection is getting less, major hepatectomy less, and the overall survival and recurrence-free survival is the same. So it's something to have in mind. We participated in a very interesting review or survey published in HPV that showed respondents of 203 surgeons, HPV surgeons from all over the world, from the 3 regions in the Americas, in the Asian Pacific, and the European side. And this study showed interesting things. First, this study was about the management of gallbladder cancer in terms of surgical. And it showed that despite all the recommendations, first, we can say that the staging laparoscopy is used only in 1 of 3 patients. I mean, not too much. Secondly, everybody, I mean, 90% of the respondents show that they use multidisciplinary discussion for this patient. That is very important. And the only different thing is that knowing all the contraindication that we show over here about the different aspects that contraindicate surgery, broadly, most of the surgeons do more surgery and more resection than the usually guidelines that were recommended. Also, we know that comparing the incidental and non-incidental liver resection, the comparison of different type of resection is similar. Only in the more advanced stages, in suspected gallbladder cancer, there are more advanced type of resections or major resections. Finally, the biliary resection is only in a few patients and very selected. And as the T stage gets more wider or going wider, you see that the lymphadenectomy increase and the type of resection of lymphadenectomy are applied is bigger. So we cannot speak about surgery in gallbladder cancer, as Dr. Vega showed, without speaking about neoadjuvant chemotherapy, because we need neoadjuvant chemotherapy, but we don't have neoadjuvant chemotherapy. This is a systematic review, very interesting, that show all the studies, but not in neoadjuvant chemotherapy, but in rescue chemotherapy, downstaging chemotherapy. And we see that almost 474 patients that had locally advanced and marginal resectable tumors, their zero resection was 35%, with a good survival in terms of months, from 18 months to 50 months, and patients that were unresectable can be rescued for surgery. On the other hand, the other type of neoadjuvant chemotherapy is the neoadjuvant chemotherapy that will improve the results of the resection of patients that are resectable from the first time. And we know that there are coming some trials about that. The two trials for incidental gallbladder cancer that was shown by Eduardo. And I will show one trial that is POLCAP from India that is going to be in 2027 about advanced gallbladder cancer, unsuspected gallbladder cancer that is coming on and recruiting patients now. So this is my last slide. Many of you have been in Buenos Aires, so we have a happy December because we won the World Soccer Championship, and I want to share this with you, everyone. Thanks a lot. Marcel is here, but
This is my Claudius Conrad, what I can call a friend, a mentor, and a boss. And he's a professor of surgery in Boston University. He had multiple accomplishments. I can go on with the curriculum, but I think you better want to listen his talk.
Yeah, nothing makes me more proud to speak in a session that is chaired by one of your mentees. So I'm very honored to be here. And on the same note, I have extremely good news for you. You only have to suffer through about 5 Kaplan-Meier curves before we can watch a video. So good news. Okay, I've been tasked to discuss with you laparoscopic resection for gallbladder cancer, and we'll talk about quality of surgery, what you have to be able to do laparoscopically to provide an adequate lymphadenectomy. Then we'll watch the video, how I do it. We'll look at outcomes, and I'll give you a brief conclusion. So, the quality of surgery matters, right? This is 2023. We know all those genetic mutations, fusion gene changes, HER2 mutation, HIF1 mutation, and all this other stuff. But ultimately, what really matters for those patients is the quality of your surgery. So quality, and we'll talk more about how is quality defined, meaning a liver resection, tumor resection, and a lymphadenectomy leads to completely different survival compared to patients who have a low quality operation. So you may be thinking, well, I'm not so good with the lymphadenectomy, but I can whack out the liver. And I'm just going to clean things up with some adjuvant chemotherapy afterwards. Turns out this is not a good strategy. If you look at this curve here, if you see the 2 bottom ones, that's low quality surgery with and without adjuvant chemotherapy. Adjuvant chemotherapy cannot recover low quality gallbladder cancer surgery. So a cautionary tale as to should you really engage on laparoscopic resection for gallbladder cancer. So I think that, most people know that liver has to come out with the tumor, but what lymph nodes have to come out? And Dr. Vega's work has been cited a lot here. He is clearly recognized as a global expert on gallbladder cancer. This is another very nice piece of work. We have heard before that incidental gallbladder cancer is about 2/3 of all gallbladder cancers being discovered. And I think you want to get a feel for what is the prognosis of this patient as to how aggressive should you be with perioperative chemotherapy or should you operate at all. And in that context, callose lymph node station 12C, can be quite prognostic for you. From that lymph node that is resected with your initial incidental gallbladder resection, you can prognosticate how things will go. This is a nice dose response here, looking at a known 12C lymph node versus an unknown versus a negative one, and you can see that there's a dose response. So you should try to figure out, if you get a patient referred to with a gallbladder resection in an outside hospital and people happen to find gallbladder cancer, you should try to figure out whether callose lymph node was positive or not. So nice dose response here. But that's, all. 12C only tells you about what's going on in the porta, in the hepatoduodenal ligament. It doesn't tell you anything about what's going on with lymph node station 16 and 13, meaning the N2 lymph node stations. When we get to the video, I will show you what you have to be able to do in order to do this minimally invasively. Next, how many lymph nodes do you have to get? Well, at least 3, I would say. You can see that having more versus less than 3 lymph nodes positive leads to vastly different outcomes. Finally, the video. Okay, can you guys play the video for me? Go back and play the video for me, please. Thank you so much. Okay, so we have published several videos on how to do it. This one is focused on the overall management of gallbladder cancer that has a complex anatomy. I will show you, for example, how important it is to remove the cystic duct stump. And I know you're thinking, right, how important can be removal of the cystic duct stump? You'll be surprised. Okay, it has other aspects that I think will be important. One is related to how much liver has to come out. Do you really have to do an anatomic resection of 4B5, or is the fossa enough? So this is a 75-year-old patient with a poorly differentiated gallbladder cancer, which is a T3 tumor. The CA19-9, which we have previously shown, is surprisingly accurate in prognosticating how patients do with surgery. The patient has a very unusual anatomy, which I will show you in a little bit, where the right posterior hepatic artery comes off an accessory right hepatic artery. So things you have to consider for the surgery. So this is a typical image you see, and you have to be mindful of the fact that this is reoperative surgery. So you can see here the accessory or the accessory right posterior hepatic artery, which runs inferiorly right there where you want to do your lymphadenectomy. So that is something you have to consider. I've said several times before, when you consider your port placement and you debate in your mind, should I go a little higher? Should I go a little lower? Always go higher. You want to be close to your target. But you have to be mindful of the fact that you will have to cochorize the duodenum and clear out lymph node station 16, 1, 2, and 3. So lymph node station 16, which is the aortocaval lymph node station, has 3 levels to it. 1 is under the left renal vein, 2 is right below it, and 3 is where the mesentery of the colon comes in and to the root, and you want to be able to clear all of this out. So typical picture after incidentally discovered gallbladder cancer. We are very nervous about residual cancer. Dr. Vega and I, we have shown previously that residual cancer is a surprisingly good prognosticator as to accurate prognosticator. It's poor for the patient. If you find residual cancer, even if you are able to find even if you are able to render the patient a 0, the prognosis of this patient is not great. So the fact that you find residual cancer after an incidental gallbladder resection is important. So here we're doing the cochorization and clearing out lymph node station 16. So the wider you medialize the right colon, the easier it is for you to get into this space to clear out lymph node station 16, 16, 1, 2, and 3. So we medialize the duodenum. duodenum. So we have to be very careful not to injure the duodenum or to have a post-procedural pancreatitis. So showing a lot of love to that part of the retraction is very important. And you see here that we are taking lymph node station 16 out, and I typically send it for frozen because I want to become a student of this gallbladder cancer during the case. So I'll send each individual lymph node station one after the other, and I become a student of what's going on with my patient. Let's say this is a patient with multiple comorbidities, a limited liver function, and I find that lymph node station 16 is positive. Maybe I'm getting less excited about this case. And that is just information that helps you for intraoperative decision making. So here I mentioned that accessory right posterior hepatic artery that runs right there where you want to clear out your lymph node station. And typically that lymphadenectomy is not so easy because somebody messed already around in the gallbladder fossa, leading to inflammation of the hepatoduodenal ligament. But you know, that's what you have to do. You have to get lymph node station 12B, lymph node station 12A, and you have to be able to clear out the right and the left side of your lymph node station. So here we are able to, we have the right posterior hepatic artery slinked on, and now we are moving to the common bile duct that you see there going from superior to inferior, and we have the cystic duct stump there. And I will show you some data that the cystic duct stump can be surprisingly prognostic. And if you have responsibility like me for a hospital network, something you need to work with the pathologies in this network is to tell you what's going on with the cystic duct stump if they find an incidental gallbladder cancer in a patient that underwent surgery for another reason than cancer. So we cleared out all the lymph nodes in the hepatoduodenal ligament. We cleared out lymph node station 16, and now we are approaching the fun part of the operation, which is the liver resection. And it is totally appropriate for, I would say, lower T stages to do a gallbladder fossa resection. Technically, it can be more difficult, actually, because it's easy to fracture the specimen. You have this little sliver, and it doesn't really makes sense to have a huge piece on liver on top where the tumor node actually is. By the time you make it to the biliary confluence, you're so close to the tumor. So you have to be mindful where is the tumor located as to planning your liver resection. This patient has a T3 tumor, so pretty large tumor, responded to therapy. In those patients, we typically do a formal bisegmenectomy 4B5. So this shows you how to do a formal bisegmenectomy 4B5, where you start your dissection. We typically along the intersegmental plane between segment 3 and segment 4B. And then here in this part where you come traversely across the liver between segment 4A and 4B and between segment 8 and 5, you have to be mindful that you will find the distal middle hepatic vein branches that can give you a lot of grievance. As you can see here, we come down very close to the biliary confluence. I like at this point to use the CUSA to minimize injury. I go to a higher tissue select, and we typically find, several dominant segment 5 branches at this point. So we are performing here the parenchymal transection. You see the specimen is almost disconnected from the rest of the liver. We are here on top of the biliary confluence. We're using the CUSA to make sure that we are avoiding an injury. And at this point, the specimen is almost disconnected and can be removed. I show you now a little fun trick that can help you to minimize bile leaks. You're right there on top of the biliary confluence, so the risk for a bile leak can be high. I don't know if you like to repair your bicycle tire, but in order to figure out where the bicycle tire is leaking, you pump it up with air, you put it under water, and where it's bubbling, this is where the hole is. You can do the same with the biliary system. And not only that, you can also confirm that you didn't have an injury to your biliary system by seeing those air artifacts you can see on ultrasound along the biliary system. We resected the the cystic duct stump very close to the common bile duct. So I was not comfortable just placing a clip there, which you can often do. Often the cystic duct stump will be very long. So in order to minimize stricturing and a thermal injury or narrowing the common bile duct, here we are closing and reconstructing this. We selectively place a drain, and this patient did really well. Okay, let me move on to outcomes. You probably were thinking, come on, how much does the cystic duct margin really matter? Well, actually, it's surprisingly prognostic. So it can be another tool to become a student of your patient's gallbladder cancer, to really understand well what's going on with the biology, because you can see that there's a 50% difference between a positive and a negative cystic duct stump. And this is also work by Dr. Vega. Finally, can laparoscopic gallbladder cancer surgery done safely and lead to good outcome? This is also work by Dr. Vega. Yes, it can, if you keep in mind the things I told you earlier today. So in conclusion, patient first. If you feel not comfortable diving under the left renal vein to dig out lymphangiostation 16-1, if you are not comfortable coming on top of the biliary confluence, maybe you should do this open. But if you have an MIS skill, and honestly, it is not that hard to reproduce what you open minimally invasively, it can be done safely, and we have shown you the data that it can be done so. So I would like to thank my team, including my mentee and chairman of the session, Dr. Vega, for their support in this work, and you for your attention. Thank you.
I really like the concept of becoming the student of your patient's gallbladder cancer, because it teaches you during the case how to proceed forward. So I would like to now introduce Dr. Rory L. Smoot. He is an associate professor and hepatobiliary and pancreas surgeon at the Mayo Clinic, and he works and studies cancers of the liver, gallbladder, bile duct, and pancreas. We are very excited to have him speak on adjuvant therapy.
Yes, thank you so much for the invitation to speak. We will get to the cases quickly because, one, I think everybody knows the studies, and two, there really aren't many there. So this will be relatively short, but we'll go through some of this. I have no relevant financial disclosures. The main disclosure is I am a surgeon. I am not a radiation oncologist nor medical oncologist. So, and yes, this is really small. Well, okay. So why do we care, or why do we talk about adjuvant chemotherapy? Because we know what the outcomes are, right? These patients do not do well. You've seen that in all of the talks earlier today. The recurrence rates are very high. The systemic recurrence rates are high. The incidence of metastatic disease, therefore, is nearly universal. And when you look at large data sets and or retrospective data, you really see this, and then you see some of the potential benefits with all of the inherent biases of these type of analysis. This is work that was done at Mayo. Dr. Bergquist, I think I know he's around somewhere. He was the first author on this, and as a trainee with Dr. Trudy, using the NCDB database from 2004 to 2012, looked at over 4,000 patients, T2 or greater gallbladder cancer with curative intent surgery. At that time, 22% of those patients had received chemotherapy. This excluded patients with neoadjuvant therapy or adjuvant radiation therapy. So really asking the question about systemic therapy. And they noted that there was an increasing use of multi-agent regimens over the time course. So as time has gone on, we've gotten more and more comfortable with treating these patients. And you can see here in those very small Kaplan-Meier curves on the right-hand side, really the node positive patients were the ones that benefited. And this is this is a rational finding here, but you can see the T2 and the T3 tumors there. So node positive cancers had improved survival with adjuvant chemotherapy, and patients It should be noted, though, again, inherent in the selection biases and all the biases of these studies, patients undergoing chemotherapy were younger, had fewer comorbidities, were more likely to have positive nodes and more likely positive margins. So some positive and negative prognostic factors. And then adjusted mortality did identify receipt of adjuvant chemotherapy as independent predictors with a hazard ratio of 0.86. So let's get to the one study that we all know about, and we talked about yesterday, we talked about in this session already a little bit, BILCAP. So this is adjuvant capecitabine following curative intent resection, excluded patients, importantly, with previous chemotherapy or radiation. There were 447 patients that were randomized in a 1-to-1 fashion. And what I'm going to do for these trials is just show you this kind of the subgroups. How many of these were gallbladder cancer patients? And so in BILCAP, it was in the two arms, it was 39 and 40 patients representing 17 and 18%. The primary endpoint was overall survival. And again, we have talked about this data yesterday, today, and for the last few years. Improvement in overall survival only in the per protocol analysis. I believe if you dig into it, that's a difference of, I think it's 12 patients that dropped out prior to treatment. When you talk about the per protocol compared to the intention to treat, there was an improvement in recurrence-free survival, and no specific subgroup had statistically significant improvement on its own. But again, we are still lumping all of these histologies together in order to get these trials done in these very rare tumors. And so they're not powered to really look at these subgroups. There's the forest plots there, and you can see very small with the big blue arrow pointing to the gallbladder cancers. And you can see that really there's no specific subgroup. And importantly, actually, when you look across the entire, all the factors that were looked at, the clinical factors, there really are no statistically significant differences between the groups there. So a really, really modest signal at best. And certainly this impacts our recommendation for patients in terms of their tolerance and side effects and whether or not they're going to benefit from that. So, but it has become the current standard of care for resected biliary tract cancers and included gallbladder cancers. So this is our standard at our institution. So we heard a little bit about Prestige 12 yesterday and again earlier today. This was adjuvant GEM-OX 12 cycles following R0 or R1 resection, 196 total patients, 1-to-1 randomization. And in this cohort, there were 17 and 21 patients with gallbladder cancer in either arm. Primary endpoints here were different: recurrence-free survival and time to definitive decrease in healthcare-related quality of life. And there was no difference in recurrence-free survival, no difference in time to deterioration in quality of life. And so this was considered a negative study. We'll bring up the forest plots here so you can see the one group that favored surveillance out of all out of the subtypes was in fact gallbladder cancer. So interesting to note in this study. So certainly again disappointing given the incidence of metastatic disease in these patients, but really no signal there. So adjuvant GEM-OX offered no benefit to patients. Okay, so we've talked about the two major adjuvant systemic therapy trials. We need to talk about radiation therapy, and there's a systematic review and adjuvant therapy for gallbladder cancer, looking at over 9,000 patients, 14 studies, and the patients that were found to benefit were patients with positive nodes or positive margins. The benefit was seen in overall survival with a hazard ratio of 0.36. This was after removing two studies that had markedly had benefits that were outliers compared to the others. So this is 12 studies with a hazard ratio of 0.63. The largest effects, again, were in node positive and margin positive patients. And you can see here, and oh boy, I wish I could read that, but I can't. I believe the top is the forest plot for the node positive patients. The middle one, I think, is the node negative patients, and the bottom one, I believe, is the margin positive patients there. So you can see benefits again in node positive and margin positive patients, and no benefits in the other groups. Now, lots of retrospective studies looking at adjuvant radiation therapy, and we certainly all know about the SWOG study that showed that there was safety without a comparator arm. And local recurrence rates are lower often in those studies with radiation therapy, but whether or not that actually translates to increased overall survival is unclear. So what about TOPAZ? We've heard about TOPAZ. Is there any signal here? Again, this was not adjuvant. This was locally advanced or metastatic biliary tract cancer, 685 patients. In this study, cohorts 85 and 86 of the total patients, 25% had gallbladder cancer. It improved overall and progression-free survival. And again, all the issues with the study design, stopping GemCis at 6 months, separation of the curves only after stopping GemCis. What we've essentially, I think, shown is that you can safely give durvalumab to patients with biliary tract cancers, and a very small percentage, likely 6, 7, 8%, are going to respond and will drive the benefit. The report is, I think, pembrolizumab is also going to be positive in this patient population, and it'll be reported out at AACR this year. So there will be a couple of options. Objective response, again, was not dramatic, 26.7% in the durvalumab arm, 18.7% in the GemCis placebo arm, and no histologic subtype analysis was done. So in summary, adjuvant capecitabine is standard of care for resected biliary tract cancers, including gallbladder cancer, based on the BILCAP trial, with very, very modest signal. Other regimens have shown no benefit, but again, the studies are underpowered for these specific patient groups. This histology-based studies are unlikely to get us there in terms of accrual for these patients, just because of the problems with accruing to these clinical trials. Node-positive patients may be most likely to benefit, and adjuvant radiation likely improves local control rates, and it may improve survival, but no prospective data to support efficacy in relation to overall survival. I think the questions going forward are going to be things like the role of immunotherapy in resectable disease. Of course, everybody's very excited to throw immunotherapy at everything, and the neoadjuvant, adjuvant, and otherwise, and those are questions that are yet to be answered. And then I do think that we have to get away from histology, and the question is going to be about the role of targeted therapeutics for appropriate candidates, and treating molecular cancers as molecular deranged diseases rather than histologies from various tissues. Thank you.
We'll have now a session of question. Dr. Melstrom is going to lead this session. She's the Chief of Division of Surgical Oncology and the Department of Surgery, and she's an Associate Professor of Surgery and Immuno-Oncology in City of Hope, Los Angeles.
Thanks very much, Dr. Vega. So I have a few questions for the panelists as we move along, and then I encourage the audience to please ask questions that really arise from clinical experience in terms of managing patients with gallbladder cancer, that perhaps there are scenarios that there's not 500 patients in a randomized controlled trial to answer the question. And that's one of the biggest limitations of gallbladder cancer, is that the incidence isn't like colon cancer or breast cancer, where you have thousands upon thousands of patients to study. So the first question I have, actually, Dr. Vega, is for you, and you cheated because you were looking on at my notes. In Chile and in places like Bolivia, where the incidence of gallbladder cancer is so high, are there any thoughts or mechanisms by which there's screening programs for these patients? And can you share a little bit about what you know?
In Chile, and Peru, Bolivia, and also associated some Chinese population, there is a relationship of the chili peppers. Chile is a aflatoxin type B that has been related to liver disease and inflammation, and there have been some study comment about causality of this aflatoxin B in the generation of in the production of gallbladder cancer. But gallbladder cancer is so strong associated with chronic inflammation and cholelithiasis that most of the screening that's been in relation to gallbladder cancer has been only screening in relation to stone and gallbladder lithiasis that is very prevalent and frequent. Chile has been decreasing the incidence and mortality of gallbladder cancer maybe for the after they start a national program of almost prophylactic cholecystectomies because of the high incidence of gallbladder cancer. That's not only warrant the surgery, but a timing resection of that gallbladder. And we have to see further whether this is actually been associated with more complication of bile duct injury that to my knowledge, hasn't been published yet. However, we did found a decrease of trend of incident of gallbladder cancer most of the time because patients don't have disease where they can produce the gallbladder disease. And we know, and I didn't mention in my slide, there is an age relation of gallbladder cancer. So we know that the chronic inflammation stone need to be at least between 10 to 15 years in situ to make the change of dysplasia and high-grade dysplasia and cancer.
Okay, great. Okay, so let's start with this case. And again, I'm going to really ask our panelists questions very much related to their presentations as we move along this case. So this is a patient who's 55. She had some history of hypertension, and she presented to us after what was noted to be a very difficult cholecystectomy with noted bile spillage. And I really want to put an asterisk by that comment, bile spillage. The pathology was T2A, N1, moderately to poorly differentiated adenocarcinoma. There was lymphovascular invasion and there was perineural invasion. And so the nuanced aspect of the pathology was that there was indeed spilled bile in the context of the gallbladder was fragmented. The gallbladder was not delivered to pathology en bloc. And so we saw a paper that Dr. Ganji presented. There's a paper that Andrew Blakely from our group published. Bile spillage is associated with survival in patients with gallbladder cancer, and almost to the extent of N1 disease. And so one thought that we had was that, you know, when you do a laparoscopic cholecystectomy as a general surgeon, you don't a priori know that you're dealing with incidental gallbladder cancer. You don't know that. And there's certain things that you have to indicate in your operative note that are critical, you know, that are standard of care, specifically the critical view, right? The critical view, you have to say you obtain the critical view, and that's part of your documentation. We propose that another part of the critical documentation is this concept of bile spillage, yes or no, because if the patient does have gallbladder cancer on final pathology, it may dictate decision-making. And so I'll talk a little bit about that. So for the panelists, what would you do? What would you do now, Dr. Ganji, if this patient presented to your office?
Thank you, Dr. Conrad. I think I'm fortunate to have excellent medical oncology colleagues. My concern obviously would be based on our discussion regarding spilled bile. Whether there was actually spilled bile or not, it's difficult to know based on the presentation you gave, but the patient has nodal positivity, potentially bile spillage. She's young. I don't necessarily think surgery would be my next step. And if the team was agreeable, I would proceed with systemic therapy. And the question to my my medical oncology colleagues would be, would they prefer to treat her with Gem/Cis, or would they consider Durva in this patient who's young based on the TOPAZ-1 data?
Okay, so N1 disease, systemic therapy, Gem/Cis, or Gem/Cis with Durva. So Dr. Lendoir, what about you?
Now, my first comment is, I'm seeing this case. This is a PT2 peritoneal-sided tumor. First, it's not very common to see these kind of tumors that are lymphovascular invasion and perineural invasion. So I think it's in the percentage of T2A that will have this N1 lymphovascular and perineural, I will address with the pathology, this is a T2 or it's not a T3, because it seems like, you know, that it's understaged.
Mm-hmm.
The second thing that I will do, there is logically the prognostic of this patient is based on the bile spile of the spile that the bile happens during the cholecystectomy. But on the other side, we don't have evidence yet to give neoadjuvant therapy in this disease. So without evidence, I will proceed with two things. First, to do a good imaging study before the surgery. And second, I think you need to do the radical resection. And at that time, I will do it for sure with staging laparoscopy before, just to know in advance if they has peritoneal disease. That probably you will find over there. It's not we proceed with the lymphadenectomy and the resection of the liver.
Okay, this is perfect. Perfect, please. It's perfect. We have two different opinions. Perfect. So go ahead, sir. Oh, please say who you are and where you're from.
Yeah, Marcel Machado from Brazil. I just have questions. The only case that we have R0 after completion of the operation, it was a patient that we operated too early. It was about between 2 and 3 weeks. Do you think that before 4 weeks of the first operation, it's too soon to do a staging laparoscopy, too soon to see an actual peritoneal dissemination happen? And the second question is about, is intraoperative cholangiography, it's the same as a spiroid bio? Because when you do an intraoperative cholangiography, we have some bio spillage. Do you consider this as a spiroid bio or not?
Yeah, this is so I'll tell you, in the US now, I don't think there is that much intraoperative cholangiograms happening. There are some, even in our own experience, complex gallbladder. We do it, but it's not like an everyday thing. And that may be a surrogate of a complex cancer if you have to do a intraoperative cholangiogram, the final pathology is gallbladder cancer. So this is a perfect question, and it's nuanced. We don't have data for this. So in N1 disease, you know the patient's going to need systemic therapy, period, end of story, right? You know that. You know the outcomes are abysmal with N1 disease. We know that the long-term survivors are essentially non-existent. And you know in this case, at least, that there's bile spillage. What is the timing of staging laparoscopy in incidental gallbladder cancer? It's a nuanced question. Well, Claudius, Dr. Conrad, what do you think?
Yeah, all very, very important question. I also agree. In fact, I cannot remember I've ever seen a PT2A tumor with all those risk factors that happens to be a T2A tumor. Just to briefly comment on Marcelo's question, how much time do we have to engage? Dr. Vega and I, we published the 6-week time frame as an important time frame after which patients have inferior prognosis if you don't engage with therapy within that time frame. I know that my friend from Strasbourg, Patrick Bissot, published early on diagnostic laparoscopy. I think in my hands, while I do for every pancreatic cancer staging laparoscopy, no matter how small and simple, I have moved away doing it for gallbladder cancer just for the fact that if it's a T2A or early T2B or so cancer, patients do okay. If it's a T3-4 tumor, I don't really think about it. I give them chemotherapy, and then I have a lot of time to figure out what's going on with those patients. So in my practice specifically, I don't use that much diagnostic laparoscopy for gallbladder cancer specifically.
Okay, great. Okay, so go ahead.
yeah,
Can I comment?
Yeah, please.
I was just going to say there was in looking at the literature with respect to bile spillage, there is a small study that included, I think, no more than 16 patients looking at the optimal time for re-resection if you would consider it. And certainly they recommended that a 3-month interval, which we can argue is too long to wait doing nothing for 3 months, seemed to obviously demonstrate metastatic spread compared to going in early. So I think that's an important point. And the question is, in this patient, would you consider doing cytologic washings? Is there anything other than just visualization of the peritoneum that could potentially guide treatment? And as we know, cytology is less than perfect, but certainly it's a consideration. But I think that was an excellent point.
One short comment. We know that we are doing a procedure that in really is not a resection, oncological resection itself, because we are doing a procedure that in terms is practically a staging procedure, because at the end, people, I mean, all the patients that had residual disease, principally the liver parenchyma, are going to be a small percentage of survival, very small percentage of survival incidental gallbladder cancer. So that's what I'm saying. I'm logically, I agree that we need adjuvant therapy in this disease to have better overall survival and recurrence-free survival. But this time, we need to do a staging procedure like the resection of liver and lymph nodes. And at the end, we benefit some patients. But on the other side, I totally agree. We need to give the period that Claudius Conrad said. I mean, 4 to 6, at least 4 weeks, better 6 weeks, and no more than 8 weeks in terms of the reoperation.
If I may just make a quick comment regarding bile spillage, there's usually a reason why people spill bile, right? I think in some ways, in my book, it is a surrogate marker for a bigger lesion that is probably on the liver side. That's why people can get into the plane between the cystic plate and the gallbladder, and they mess it up and they have bile spillage. So for me, it is a surrogate marker of a higher stage gallbladder cancer. I can repeat your question if you like.
There's another quote.
What, 100% yes. Because it's going to spill as you're manipulating the gallbladder. So that 100% yes. Different, a little bit different than the cholangiogram catheter.
MRI with UVS, without UVS, PET has an role, and that's
So let's do this patient, and then I want to hear what the faculty have to say. So for this patient specifically, because she had N1 disease, I ordered a PET scan. But the first thing I did, I did 2 things. One, I went to see if she had any imaging done at the hospital before her surgery, because usually they just have an ultrasound, that's all they have. But she had a CT scan, and these were some of the kind of the sentinel images demonstrating why perhaps the gallbladder was in pieces. It was a very large gallbladder, essentially folded on itself, but no definitive signs of malignancy. And then she had a HIDA scan showing that the gallbladder didn't fill. So, very appropriate. The patient had a cholecystectomy. I would not, in retrospect, go back and say that the initial general surgeon did anything, untoward. But for this patient, I did 2 things. One was what Dr. Lendoir said, was go back to your pathologist, Callot's lymph node, we already knew that. See if the gallbladder was intact, we already knew that. The cystic duct stump, that was the comment of Dr. Conrad in his presentation. This patient's cystic duct stump was negative. If it was positive, it just changes immediately how you think about the patient, because you are with 100% certainty going back to the operating room and likely dealing with both the cystic duct stump and potentially doing a bile duct resection. It's almost, invariably that's going to be part of your future operation. I like to know if it was on the peritoneal or on the hepatic side, if possible, in addition to the T and N stage. So 4 things: Callot's node, intactness of the gallbladder, cystic duct stump, and then the location of the tumor. And then so those are the two things, the pathology and getting the preoperative imaging. So for this patient, because she was N1, I got a PET scan as my first imaging modality. And you can see two things, and the folks here presented on these two topics. So you can see that there's residual uptake in the nodal basins where surgery was. So there's, documented at least PET avid potentially residual disease. The second thing you see is perhaps a little uptake at that port site. That early post-op, I didn't lend too much credence to that. I said, I'm just going to pause on that and we're going to see. But because of that nodal imaging, I could either say, okay, this is probably nodal disease. I could put the patient through an EUS. I could do a diagnostic laparoscopy. But the next immediate thing that this patient needs that's going to probably impact their survival is systemic therapy. And so that's what I ended up doing. But I want to hear what the panelists have to say in terms of what imaging modality is there first after a patient presents like this.
I would say the most important is a high quality CT scan. You can tell a lot from it, and you can get the initial assessment of the lymph node stations. I think the main role for PET is maybe for N2 lymph node station assessment. It can be helpful. I think in our healthcare climate, it can be tough to get a PET scan in time to move on. And I think worse than really knowing what's going on is delaying therapy. So most of the time we forego it. I think having a high quality CT scan tells you a lot, and that's basically all we use.
We use CT regularly, except in jaundice patients. We use MRI. And the PET CT only, we use PET in selected patients with marginal resections because it's very expensive in Latin America.
Yeah, it's expensive here too. So she had her CT from her local oncologist, but okay. So, okay, based on these imaging findings, is there anybody in the audience or in the panel that would proceed to surgery at this time?
So, no, and I think the thing that, everybody's going to have their own way that they manage this in these locations, because we're in somewhat of a data-free zone. But I think that these patients essentially should, from my viewpoint, be considered metastatic until proven otherwise. So I am not trying to decide who I'm going to treat with systemic therapy first, because I think that's what they all need. I don't think that we fix very many, if any, of these patients with more or bigger surgery. I am looking for those unique patients that have the perfect setup, right? No spillage, easy operation, incidental. There's no evidence of nodal disease for consideration of upfront radical cholecystectomy. Otherwise, I agree, everybody needs systemic therapy. And it's tough because the systemic therapy is not great, but the surgery isn't either, unfortunately.
So one other point that's applicable for biliary tract cancers now in 2023 is that when they present to you and you're not going to operate on them and they're going to get systemic therapy, and you know that they're not going to end up in the operating room and they progress on systemic therapy and then they're going to go on second line, they're going to need other options. So it would be much easier to go ahead and get your molecular profiling right out of the gate, so that when they do need that second or third line, you have options already prepared for them, rather than making that decision, 4 months down the road.
I think the most important thing here is the port. I mean, the port will define the probably more the survival of this patient than the node itself. I mean, I don't know if with only a node we will go first. I mean, there's no evidence that we will have better survival going radical surgery in residual disease. If you can do a good radical surgery comparing with chemotherapy before now. So I think in our view, if it's not disseminated disease, it's only one node, and the port side is not an infiltration on the wall, we will proceed with surgery.
Yeah. For us, it was more to see how it plays out. You just give the patient some time. So she just got 3 cycles of GemCis, and she ended up getting another PET scan. In the interim, she fell and like broke her clavicle, so she missed the cycle, but 3 cycles of Gemsys. This was right at the moment where durvalumab was about to be approved. And so these are her findings now. And what would the folks do now?
So, I mean, looking back at what happened, the patient progressed with the Gemsys treatment. So, analyzing the situation, we can say that I don't know if we're going to cure with the radical surgery the first basis, but you know, is the usual that happens sometimes with neoadjuvant chemotherapy, this patient or chemotherapy, no?
Yeah.
Yeah, I agree. You know, that tumor is sending you a message. I mean, if you're talking about 3 cycles, so in 6 weeks, the thing is already spreading to a different lymph node. So the biology is really, really aggressive. Yeah.
And so in very short order, she presented with a liver metastases and biliary obstruction, and 9 months post the initial operation, she passed away. And this is the issue with gallbladder cancer. And I chose this case to present in that exactly what Dr. Conrad said in the beginning is we are students of this disease, and some of the patients will catch extremely early, and we will be able to intercept, and our surgery could potentially offer them a life-saving benefit. But if their biology is so aggressive, we really need to heed that and be a student of the tumor. Thank you all very much for participating in this panel. It was lovely to learn from you. And any other questions from the audience? Okay, great. Thank you very much.
Great session.
So, nice to meet you.
Because you are showing what's happening with the disease.
Thanks for including me. Appreciate you. Yeah, great case. Yeah, no. Yeah, of course. Yeah. I thought it would be a good recap.
Perfect. Very aligned.
Yes, yeah.
Thank you. Great job. Nice to meet you. Yeah. Now I understand why you were expert in gallbladder. That's right. It tracks. Hi there.
Hey.